Hi, this is Lisa, and today we're going to talk about Chapter 16, the communication process. So when we talk about communication, we're talking about the exchange of messages between a sender and a receiver. I'm sure if you've already had speech, you've gone over this, so this is a review for you. But there's a little bit of a difference when we talk about healthcare communication, and we'll get into that in more detail in a minute. So we get this message from a sender. The sender's going to create a message, and they're going to send that to the receiver. The receiver's going to get that message, and we know that we have successful communication when the receiver interprets the message correctly. That's the goal. So communication is so important in healthcare for a number of reasons. First of all, there is a huge network of people and providers in healthcare. So we're talking about primary care offices, specialist offices, physical therapy, occupational therapy, testing, lab testing, diagnostic testing, insurance companies. So all of these people are in the communication loop in healthcare. So we have to make sure that we are providing information that each of those agencies or areas need. And that's why it's very specific to healthcare, because it's different types of information. The reason we want to have good communication in healthcare is because when we communicate properly with all of these entities, we are able to provide and coordinate a patient's care. When you look at the statistics, about 66% of medical errors are due to poor communication. And that's a little frightening. Just think of your own personal experiences when you've said something and someone has totally misconstrued or misunderstood what you said, and they've done something totally different than you wanted them to do. The same thing happens in healthcare, but we can go very wrong if we're not very careful. Communication in healthcare is just as vital as the skills that we learn. So if we do phlebotomy, if we do clinical things like injections, vitals, if we are helping in the operating room, whatever it is that we're doing, it is equally or maybe sometimes more important than those technical skills. Because when we communicate effectively, our patient outcomes actually increase, which is pretty impressive. So why are there reasons, what are the reasons for an increased need for competent communication? Well, there's a lot of them, to be quite honest. So one of them is because of insurance and the complexity of trying to understand insurances. I'm not sure if you've ever had to contact your insurance company for anything, but it is very difficult to get through a conversation with them, because what's happening is we are talking to someone who's working in a call center and has no education or no understanding about the insurance. And so the communication can get sticky sometimes. So is it covered by our primary insurance? Is it covered by our secondary insurance? What drugs are you eligible for? What drugs are on the formulary? What drugs aren't? There's just so many things that surround our insurance. And think about being an older person who has to yearly look at their insurance, their Medicare, and make sure that they have the very best plan and the very best drug plan. It gets very interesting when You watch these people have to make those decisions. That's why in our community, we have people that specialize in this and that can help the older population who are eligible for Medicare through this process and choose the one that is truly best for them. Another issue is patients are spending less and less time in the hospital, which means that they are going to need a much higher level of follow-up care and the need for very clear instructions. We also have a shift in the major cause of death. For many years, it was infectious diseases. And now it's from chronic diseases because our lifespan is lasting so much longer than in the previous decades. So we think about things like heart disease, cancer, COPD, which is chronic obstructive pulmonary disease, and stroke victims. So what we need to be able to do is we need to be able to provide the best information and as clear as information as we can to help our patients be well and live healthier lifestyles. So when we talk about communication and patient well-being, you have to remember that the most important thing is that we have to respect our patients. Your attitude actually affects how you communicate with patients. You need to respect them. You need to have compassion for them. So let's think of some things that may be stressful for patients. Put yourself in this situation. Think about a time you've been at the doctor and you've maybe waited for results. You've been sitting there too long, and remember how you felt. So again, waiting for test results. If you've had a biopsy and you're waiting for results to see if it's cancerous or benign, that you're going to be anxious. Pain plays a huge piece in that. People think differently and act differently when they are in pain. The one thing that we have to remember is when people are going through these processes, they are actually losing control over part of their life. And that is very scary for people. So what they'll do is they'll lash out and be able to control one aspect of their life because they've lost so many other things that they can control. They don't mean to be nasty to you, but they're trying to live with this new reality that they have a loss of control over what's going to happen for them. The other thing is that then on top of that, we need to add physical issues that they have going on. And when we put the two together, what we see is there's so many stressors for that patient that it actually can negatively impact their recovery. And that's what we want to try to avoid. We know, again, that poor communication can lead to fatal errors, drug errors, information not being passed down correctly, lab values being given that are incorrect. So we need to make sure that we are very careful with that communication process. So when we look at our population, and we look at the people that are struggling with these stressors and losing control over part of their life and chronic diseases, and generally this is our older population, there's a huge piece that comes into play, and that's their loneliness and possibly depression. And this is important to remember because there's not a lot of people that may be in their age group that are still here. I remember a situation where my dad was so sad one day, and I said, "Dad, you seem really upset today. What's going on?" And he said, "Well, I just look around and all of my friends are dying. And I realize that I'm going to be alone here pretty soon, and I'm not going to have anybody to talk to." And that was really upsetting to him. And we need to remember that as we see our patients. Sometimes it's just listening to our patients that makes such a difference to them. So it's our responsibility to look at the patient, assess where they are, and be able to see if there's anything we can do through communication to make our patient feel better. So, health literacy. Why is it important? Well, health literacy is actually the ability of our patients to be able to obtain and process basic health information. And we normally say, well, they do this all the time. That is really not the case at all. And actually, I have put on Brightspace a video that I need you to watch, and then worksheet for chapter 4 goes with that. I don't know why I called it chapter 4, but I did. But the worksheet goes with that. And you're going to see there's a number of times people do not understand what's happening to them, the medication that they're taking, the diseases that they have. So it's very eye-opening when you watch that video. When we look at the community and the country at large, we have an 8th grade reading level. That is the average reading level for the United States. We have to make sure that when we're talking with patients, that we're talking to them in a level that they can understand. We do not want to use big medical terms. We don't want to use words and abbreviations that they've never heard. They're not going to understand it. And again, they're not going to ask questions because they trust us, or they think they're going to look stupid if they ask a question, which is the furthest thing from the truth. So I'm anxious for you to be able to see the video and complete the worksheet. And just so I get your feedback on that and see if that's really, truly what you feel is going on in healthcare. It was eye-opening for me. One of the things that we need to also think about, there are other reasons related to communication that patients don't follow medical advice. So, we already talked about they don't understand, what we're saying. That's a big piece. And they're too embarrassed to talk to us. 39% of our patients might disagree with the recommended treatment. And they're afraid to say anything, so they don't. 27% of our patients are concerned about the cost. Think about this for a minute. You're on a fixed income, you're on Medicare, Social Security, and all of a sudden the doctor wants you to have some very expensive testing done, or prescribes you a medication that's very expensive. How are you going to pay for this? How are they going to pay for this? We have to think about those things when we're looking at our patients, and if they follow through with treatments and medications, and if they don't. We don't want to yell at a patient when they bring their meds in and say, "You're not taking this medication, what's wrong?" We may want to say in a very different tone and a different way, "I notice that you have an awful lot of these pills here. Is there a reason you're not taking them?" And that line of questioning is they're going to be much more open, rather than accuse them of not taking them and then they don't tell you the honest truth. 25% of our patients found out that the instructions we were giving them for self-care were too difficult to follow, so they weren't able to follow the instructions. 20% felt that they were against their personal beliefs. And 7% stated that they didn't understand what they were supposed to do. So this is really important as we look at communicating with the patients that we deal with. We need to find out if they understand what we've communicated to them, and if they did, we can ask them to repeat it back to us, and that's one of the best things that we can do, so we can find out if they really understood what we were saying. So, communication, again, is a lot more than just talking and listening. And when we look at therapeutic communication, this is when we see the communication differ a little bit in healthcare. This is where we're really focusing on the needs of the patient rather than the general communication cycle that you may have learned in speech. This is an art. Communication is an art and a skill. And that's something that sometimes it takes a little bit of time to become good at it. And it's something that we should all be striving to be the best at. So when we look at the communication process, there are 6 steps that we're going to talk about. The first one is set communication goals. The second is to deliver or create a message. The third is to deliver the message. The fourth is listen to the response. 5 is offer feedback and seek clarification. And the 6th step is evaluate the encounter. So we're going to talk about each one of these differently. So this is the therapeutic communication model. Again, here we're going to set our communication goals. We're going to create the message. We're going to deliver the message. We're going to listen to what the response is, offer our feedback, and then evaluate that to see if we need to redo anything. So this is the communication model that is in your book that you will be asked questions on. This is the big business communication cycle model, where we have a sender and they're sending information, a message over, and the receiver gets it. But along the way, there's this stuff called noise. We're going to have noise as well. So those are things like the temperature of the room, fear, the inability to understand what they're saying, the noise. Some people, the noise in medical offices is so distracting to them that it's very hard for them to understand what's being said. Okay, so we get the receiver gets the message, then they have to try to make sure they understand what the message is, and they offer some feedback, and then it comes back to the sender. Again, when we talk about channels, there's a number of channels. There is oral communication, written communication. We now have text, email, fax. All of those things are ways to communicate with our patients. So let's talk about step number 1, set communication goals. So we have to figure out what we're trying to accomplish. So this is a little different than everyday conversation. Hi, how are you? So let's say we go into the room and we want to find out how our patient is. We know that they're going to say, I'm fine, but that's not a good answer. So we need to be thinking of what we want to get out of that conversation. Okay? So we're going to ask much more specific questions, like on a scale from 1 to 10, what is your pain level today? Are you feeling nervous about the procedure that you're going to have? How are you eating? Did you eat breakfast this morning? And if so, what did you eat? Those are the type of questions that we can ask to get much more rich answers and information that's going to help us determine what the patient might need. So your book actually on page 341 offers some example of healthcare goals. The first one is to gather objective and subjective information about a patient's condition. So we're going to go in and we're going to do vitals. We know that those are objective: temperature, pulse, blood pressure, respiration. But we're also going to do that chief complaint. What are you here for? I have pain in my cheek and my ear is just throbbing. So what's going on with the patient? Try to figure out what's going on. Maybe it's a patient that's coming in for a pre-op visit and we need to do patient education on post-surgical home care. We do this a lot because once you come out of anesthesia, you're not there. You're in a different world. So we try to do the post-op teaching prior to the patient having the surgery so they understand it and have time to process it before they go in. Inform a patient about the benefits of a recommended treatment, or report patient care information to a coworker or to someone that you're talking with about this patient. Okay? So we need to make sure that when we interact with our patients, we have certain things that we need to do. So we need to make sure that we are sincerely concerned for our patient. Patients can tell. We need to smile, and not just with our mouth, but even with our eyes. You know when somebody's giving you a fake smile. We're very gentle in our manner. We don't yell at them. We don't rush them. We give them the space that they need. We don't hurry them. And we listen carefully to what they're saying. Don't be doing 10,000 things while they're talking, because then they're going to feel like you're not paying attention to them. You need to establish trust. And that's going to be usually with eye contact. Now, in certain cultures, eye contact is not okay, but in many cultures, it is. So when you're talking to the patient, you need to be looking at them and letting them know that you're giving them your undivided attention. We're going to explain to them what we're doing and why we're doing it. We're going to let them know what we're going to do in advance so they're not startled or scared. And we're going to make sure we follow through with what we promised the patient. And this is the one that gets my goat. Because they'll say, oh, we'll call you back by this afternoon and you'll have an answer. And 2 days later, nobody has called. So don't promise things you can't deliver. Make sure if you promise something, you can do that. So if you place a patient in a room and tell them, we need you to get undressed. I'm going to be back in just a few minutes, no more than 5, and we'll be back in and start with your vital signs. You need to make sure that you are back in that room within that 5-minute period of time. We also need to work at enhancing the patient's self-esteem. And this means involving the patient in decision-making for their care. This is something that hasn't been done as much as we should in the past, but we're starting to see many more physicians going to more patient-focused care. The other thing we can do is clarify what the patient's saying to us if we don't understand them. There's a lot of times people will say something to me and I have no idea what they mean. So instead of just saying, okay, I'm going to ask them to help me understand it or help them clarify for me. You need to make sure that you're addressing the patient properly. Mr., Mrs., Ms., doctor, no honeys, cutie pies, huns. That's not respectful. Some patients will ask you to call them Lisa. I do when I go to the doctor. I don't like to be called Mrs. Rocks. So I let them know that. But generally, we will call the patient Mr. or Mrs. as we address them. We need to make sure that we provide privacy for our patients. And when it's appropriate, we need to ask the patient on input on how they would like things to be done. So, question for you. True or false? Today's healthcare services are so technically advanced that there is little point in allowing patients to participate in making decisions about their health. Well, hopefully you're going to answer false. Patients absolutely should be involved in decision making whenever possible. The second step is to create the message. So what we want to do is we want to take the information that we gathered, look at the communication goal, and base the question on what outcomes we want. We do not want to use medical terms with patients. There's nothing worse than walking into a patient's room and saying, well, we've scheduled you for an EGD and a chest x-ray, and you're going to have a BE, and the doctor will get back to you about that. They have no idea what we just told them. So don't use abbreviations. Don't use medical terms. Talk to them. Explain to them what the procedure is. Let them know if somebody needs to be there, and take them home and stay with them after a procedure is done. These are very important things we need to make sure we're communicating. So, we also have to determine what the level of the patient's understanding is. And this is really important. So, do we have a young patient? Because if we've got a child or even a toddler, what we may want to do is come down to their level, because towering over them, talking to them, is intimidating. I mean, think of yourself. If somebody is taller than you and they're looking at you and going to come at you with all these different things, we're going to be intimidated. The same way with a child. And so those are things that are really important to think about. Does our patient speak English? If they don't, we're going to have to figure out something pretty quickly. Is English their second language, possibly? Does the patient have a learning disability that we need to be aware of? That might affect their ability to understand what we're saying. Is the patient confused or disoriented? Maybe that's one of the reasons that they came in for the visit. If they're disoriented, how much information are we really going to get from them? And is it going to be accurate? What is the patient's ability to retain information? Are we looking at people who have short-term memory loss? And if it is, then whatever we do needs to be put in writing, because they're going to walk out of their office and they're not going to remember a thing that we just told them. We also need to think about emotional factors. Is our patient anxious? When you're anxious, you're not going to hear, you're thinking about all those internal struggles you're having, and you're not going to be able to focus on what somebody is saying. Is our patient really ready to get the information that we're telling them? So let's say the doctor just walked in and gave them a diagnosis of malignant cancer. What we don't want to do is overload them at that point in time with all the services that are available, everything that they're going to be able to do, the treatments that they're going to be doing. Because I can tell you, they are not going to be listening. They are in shock that they have cancer, and they are not listening to a thing that we say. So we need to take that into consideration. Again, we need to think about physical factors. Is the patient in pain? Are they on medication that causes them to be drowsy or affects their ability to concentrate? Do they have a hearing or a speech or visual problem that could affect the communication process? And we need to think about if the communication is urgent. Is it something that we have to do right this minute, or can it wait? So excuse me, when we look at creating those messages, we need to make sure that it's clear and concise and accurate. If we have a long message, which sometimes we do, you need to rank those in order of importance. We need to make sure we're giving an overview and then the details, and try to break information into chunks. This is what we do when we teach. We're going to talk about the most important things that we want you to remember. We're going to give you an overview, and then we're going to break it down so we can help you understand it a little bit better. Messages can absolutely be in the form of a question, and sometimes those are very, very telling type communications. So when we talk about different types of questions, we have close-ended questions. Close-ended questions are ones that can be answered with one word or phrase. Like, did you eat breakfast this morning? Yes. Did you take your medicine this morning? Yes. Those are appropriate in some situations, but in some situations, we need additional details. So then we need to be asking open-ended questions. And that type of question, you have to give a response. So let's go back to the breakfast. We asked our patient, did you eat breakfast? Yes. Well, what did you have? That's that open-ended question. And they'll go, oh, well, I had to have a piece of dry toast and a cup of coffee from yesterday because I just don't have a lot of money for food right now. And that's what I'm eating just to get by. That's very different than eating breakfast. So sometimes we need to ask those questions. There's also different types of questions out there. There's probing questions. So we are going to ask questions that is going to give us more information. So if your patient says, my stomach hurts, we're going to ask them, well, where does it hurt? Where is the location? Are you doing anything when the pain starts? Is it a dull pain? Is it a sharp pain? Those are things that you can use to help find out additional information. Leading questions are along that line as well. And the pain one that I just said, is it sharp, dull, throbbing? That's really more of a leading question because we're giving them the answer. We gave them a lot of answers, but they have to choose one that's going to answer what's happening with them. So another example of a leading question is, do you feel more nauseated in the morning, afternoon, evening, or during the night? They're going to have to tell us that. And so we're giving them the options. It's just they have to choose, think about it, and choose the one that's best for them. When you're asking questions, you need to leave time for the patient to process and think and then respond. 15 seconds sounds like or feels like 16 hours sometimes. But we have to remember, some of our patients are older and it takes a little bit for those synapses to connect. It takes longer. And so it may take them a little bit longer to be able to process. The patient really may have to think about it, and it may take them a little bit of time. Well, I don't know. Is that a dull pain? Is that a sharp pain? Or if they've had a stroke, sometimes there's a delay in what their brain wants to say and being able to get it out. And so we need to be patient. Please don't rush your patients because they're going to get frustrated and it's going to be very upsetting to them. If they don't understand the question, you can reword it. Maybe you can say it in a different way that's going to maybe be easier for them to understand. Use humor. Now, I say this, but it needs to be appropriate. I use humor all the time. I have inappropriate laughter when people fall. I'm bad at this. But we only use humor when it's appropriate. maybe to relieve tension. So we need to be very careful about that. Sometimes we can use a little bit of humor, maybe to open up an issue that they may be feeling a little bit sensitive about. So we break the ice a little bit, laugh, and now they feel more comfortable and they're able to use that break as a way to introduce this new topic that they want to talk about. One of the things that you are going to see is that our patients may joke, but they're doing it to mask fear. And they do it to cover up with how they're feeling. If they're embarrassed about it, they may make a joke. What we have to do is do not, under any circumstances, buy into that joke, because that they're saying that because they're uncomfortable. What we have to do is just listen to the patient, find out where they are, what are they, what are they most worried about, and let them know that we are there for them to talk if they need to. So again, the patient was just diagnosed with cancer. They come in and they go, well, I guess you won't be seeing this hair very long. And they'll laugh. Essentially what they're saying is, okay, I'm going on chemotherapy or radiation. I'm scared. I don't know if I'm going to lose my hair. Don't know if I'm going to not lose my hair. So that offers a door to open up to say, it sounds like you're kind of nervous about this. Has anybody explained the process to you? So it offers a door to open that allows us to be able to talk about the situation that they may be anxious about. So question 2, what is your date of birth? Is an example of what type of question? Is it a probing question? Is it an open-ended question? Or is it a closed-ended question? Well, it is closed-ended because we can answer it in one short phrase. So if we don't have to provide detailed information and it's just one word or a short phrase, like your birth date, that is indeed a closed-ended question. Question number 3, true or false? An appropriate use of a leading question is with patients who are unable to offer complete answers on their own. So think about that for just a second. And the answer is true. If our patient is really finding difficulty in what they want to say, sometimes using those leading questions does help them be able to formulate their thoughts a little bit better. So on page 343 at the top, they have really good examples of closed-ended questions, open-ended questions, probing questions, and leading questions. The third step in the communication process is delivering the message. And when we talk about delivering the message, we want to make sure that we are addressing the patient whenever possible. Even if we've got very old patients or young patients, we still look at the patient. We may ask a question, but we still want to have eye contact with our patient. Okay? So, when somebody brings their 87-year-old mom in and they ask, how's your mother doing? We shouldn't be asking how the mom's doing. We need to be asking the 87-year-old patient how they're doing. And if they can't answer well or properly, then we can ask the daughter or son or whoever brings them in how they're doing. Don't bypass the patient. It makes them feel devalued and that you don't really care about them. And so it's very important that you think about that. Okay? Also talks again about using Mr. and Mrs. and no honeys and sweetie pies. That irritates me. And Another thing that you need to think about, this is one area that I had a very difficult time with. If you're dealing with a certain culture, it may be that you don't talk to the patient and you talk to whoever it is that has been deemed the speaker for them. So we would have people from Middle Eastern countries come in, and their husband would be there and the wife, because, okay, remember I worked in OBGYN, so the wife was pregnant. And I would say, how are you feeling today? Looking at the patient, and he would say, she's fine. And I thought, well, okay. Irritated me a little bit because the woman was not speaking. She let the man speak for her. But this is one of the lessons I had to learn. I had to learn to respect that, because that's their culture. It's not what I liked. It's not what I would want somebody to do for me, but it was their culture, and I had to learn to respect it. And so when we would make an appointment, I still would look at the patient and say, well, when would you like to come back? And the husband would say, well, let's schedule it for, and we can absolutely do that. That's not a problem. I still like to make eye contact with that person. Again, unless it is not culturally acceptable, and in some cases it's not. But I do like to try to make sure I know that I'm addressing them as well. Some of the other things that we have to look at is we need to be very careful if someone is speaking for the patient that we are not breaching confidentiality. Just because that's their culture, it doesn't mean that we release information without the patient's permission. So we have to get a release of information signed for that patient, that the husband can be there to hear this information. That's very, very important. We also need to be cognizant of people who are not able to communicate. And this is important because we're going to have situations where patients aren't going to be able to talk. And we'll talk a little bit more about that when we get to the specific scenarios towards the end of the chapter. Okay, nonverbal communication. Whoops. I'm going ahead. And I shouldn't have. There we go. Don't look at that. So, true or false? Using casual words such as like and you know in your messages to patient can help them feel more at ease. Well, if you were quick and you saw the answer, it is false. I love Judge Judy, and she calls those filler words. We do not use them. We want to use nice, concise communication because the patient may not understand what we're saying, or it can irritate the heck out of them. So please don't use those filler words. So we need to talk a little bit, actually a lot, about nonverbal communication. When we talk about the way our body is positioned, our eyes, our arms being folded, that's nonverbal communication. And that makes up 70% of the meaning of an oral message. I want you to think about that. So I say to you, how was your day? And you go, huh, fine, and roll your eyes. You said fine. So if I just took you at your word that you were fine, I'd go off and be happy. But I saw your tone change. I saw the inflection of your voice change. And I saw your eyes roll. Those are all nonverbals that are telling me, even though you said fine, you're not. Okay? So, nonverbal communication includes the tone of your voice, your body language, gestures, facial expressions, touch, and your physical appearance. And this is something people in healthcare sometimes forget. If you come in looking like you just rolled out of bed and a cat licked your hair, patients are going to look at you and think, my God, you can't even take care of yourself. How are you going to take care of me? And that's why it's so important that when we work, we are clean and no wrinkles and we look acceptable. Excuse me. So, again, talking a little bit about body language, they can be negative or positive. We can smile. That's a positive gesture. But we can also cross our arms and roll our eyes. Now, we have to be careful about reading into certain things. Eye rolling, you can't read anything in. I hate to have people talk to me and roll their eyes. I want to poke their eyes out. But I don't. But crossing their arms, a lot of times people will say, well, they're blocking out what you're saying. They may be cold. They may be sitting there with a paper gown on and the air conditioning vent is right above them, or they may be nervous and they're cold. And so they're crossing their arms for body heat. So we need to be very careful at assuming somebody's crossing their arms because they don't want to hear what we're saying, as opposed to being cold. And I would actually say to a patient, oh, are you cold? You're really kind of holding your arms there. Well, yeah, I'm freezing. Well, would you like me to get you a blanket? Oh, that would be wonderful. Takes care of that. We've taken care of it. I don't have to worry about that situation. Okay? Facial expressions. We can always be careful about disgusting or negative reactions. Impatience, you're tapping your foot, you're just rushing them along. Those type of things it's very upsetting to patients. Now, the one thing that I want to say is we have to be very careful when you're in healthcare and you're doing something with a patient and there is odor or there is something that's not too pretty. We also have to remember that the face stays the same. We can't go and make our face you can't see me, but make your face all crinkled up and gross, because then the patient's going to feel horrible. So there's times that you look at something and you think, oh my God, how have they been able to handle this? But we cannot let our face or our nonverbals show that to make the patient upset. So, question 5. Leaning towards the speaker when you're listening is usually a sign of aggression, interest, or difficulty understanding. And I hope you chose interest, because as we lean in towards someone, it's showing them that we're interested in what they're saying and we want to hear more. Okay. Looking at our patients, leaning towards them, nodding your head, holding your body in a relaxed position, not tense, smiling, those type of things make the patient feel like you're listening to them. Don't be typing information into the computer and talk to them at the same time, because they're going to feel like you're not listening to them. So we need them to make sure that we know that they're focused on what they're saying and we're listening. Factors to consider when we're delivering the message. Where's the light coming from? If they're standing in front of a window where the light's bearing in or glaring in and they can't see, and they're all squinted up, and we need to be very, very careful of that. Can we see them? Can they see us? Sound distraction, I talk a little bit about that. Can we hear them, or can they hear us? Is there a noise that's affecting them that they may not be able to hear us correctly? Make sure that we provide them privacy. We don't want to talk about something in an area where other people can hear them. And we need to be careful on how loud we say things. We want to make sure that we're focusing on our patient and the patient is comfortable. That is it for the Chapter 16, Part 1. Chapter 16, Part 2 is right behind. Thanks.